The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everyone, and a warm welcome to you tonight as I invite you to join us for tonight's RX Question Lab workshop, where we are going to focus on the renal system. So it is fantastic to see all of you guys here on a April night, spring night. Hopefully the weather is all right in your corner of the world. Tonight we're going to dig into renal. This is a key area for any aspiring physician. Big component of step one. So there's a lot for us to learn. So I'll just start off tonight. My name is Jeff Downing, and I'm going to be your co-host. We're going to be reviewing some board-style questions. We're going to work on, as much as possible, trying to illuminate some of the key high-yield concepts while providing you with tools and strategies that you can use to answer these items on upcoming self-assessments, upcoming exams, and eventually on the boards. I am joined tonight by Dr. Abraham Titus. Abraham, would you like to introduce yourself to the crowd?
Yes, thank you, Jeff. So my name is Abraham. I'm a hematology oncology fellow at the University of South Alabama. I've tutored with Scholar RX for the past, I don't know, let's say 4 years, 5 years, probably longer than that. And I've helped many students such as yourself excel on their boards, and I'm excited to be here and learn a little nephrology with everybody.
Excellent. So Abraham has a ton of wisdom to share. So you just make sure you've got your notebook handy here. He obviously brings a ton of knowledge and expertise, and hopefully the tips and advice will kind of enrich the discussion and our learning experience tonight. We're also joined by Kat, and she is going to be working the question box, answering the questions that you put in there. So if you've got questions or reactions or suggestions, whatever, go ahead and head to the question box. So with that, you know a little bit about us. We'd like to learn a little bit about you. So what we're going to do is we're going to launch that first poll of the night. And once we do that, give you a chance to answer. Who are you? An M1, M2, M3, M4, or you're an IMG or an FMG? Make your selection. Looks like the polling system is a little slow tonight, maybe a little wonky, so we'll keep it open. So we use the quick poll function in GoToWebinar for all of the questions. So once you've determined that you can figure out how to choose your answer choice, that's all you really need to know. And we keep these polls open until roughly 3/4 of you have voted. Once we hit that threshold, we close the poll and we share the results. So that's what we're going to do tonight. We'll let me close the poll and share the results. And so it looks like we've got a lot of M2s here in the crowd, quite a few IMGs. So I'm assuming that some of you are perhaps in dedicated right now. If you are, go down to the question box, let us know. It's that time of year, right? We also have some M3s and M4s here, and a few M1s. Curious, wondering what this is all about. So regardless of where you're at, we're really glad you're here. So anyway, let's go ahead and get ready to get started here. Again, here at USMLE-Rx, we believe that answering board style questions, NBME style questions, is really one of the highest yield activities that you can engage in while prepping for STEP. But these questions are complex, and without the right approach, sometimes they can seem insurmountable. And our mission is to help you develop the skills to dissect these types of questions effectively and efficiently. So tonight, as we do this, we're going to break down these questions together in real time and talk not only about the content but also about your strategy for attacking these questions. So again, get your notebook out, and we'll see what we can do to make the most of this opportunity to learn, grow, and conquer our exam goals together. And at the end of tonight's event, we will have a raffle. Someone is going to walk away with a free subscription to RX 360 Plus. But you do need to be here in order to win. Okay, with that, let us go ahead and get started with question number 1. Again, we're going to focus on methodology here, and when I display the screen, you're going to see something's missing, or perhaps some things. That's right, there's no answer choices here yet. That's a part of our method. We advise you to, when you approach a new question, you go ahead and cover up the answer choices. This is all about focus. And one thing that can happen is, you look at some answer choices and you see some options that you're either not familiar with, which is probably rare, but it does happen, or something that's given you trouble in the past, or something that confuses you. And so, what we want to do, what we want you to do, is to really, focus on these things one part at a time. So we just want you to be methodical, cover up the answer choices, and then we want you to read the lead-in. And the lead-in is the actual question here. Okay, so we don't want you to read the patient story yet. We want you to read the lead-in. And in this case, the lead-in is, which of the following effects is the patient's new medication most likely to cause? Okay. Now, there are a number of advantages, obviously, to reading the lead-in first. One of them is that every so often, you're going to come across a lead-in where you don't even need to read the vignette. You don't need to read the stem. You can actually get right to the answers. That's pretty rare in step 1 these days, but it does happen. But secondarily, what it does is it helps frame the question for you so that you know what kind of information you're going to be looking for when you read the vignette. Okay, so if you just read the vignette blind and then get into the lead-in, you're like, oh, I'm supposed to be looking for following effects. Okay, there's a medication. That's what I'm looking for. Okay, so again, so let's think about our steps here. We cover up those answer choices. We read the lead-in. Now we read the vignette. A 37-year-old man with diabetes mellitus and hypertension is found to have 100 milligram albumin in a 24-hour urine collection. He is prescribed a medication that will improve his blood pressure and reduce his albuminuria. So again, which of the following effects is the patient's new medication most likely to cause? And what I want you to do, if you go down to the question box, let us know how many steps you think it's going to take to solve this one as I turn it over to Abraham.
All right. Thank you, Jeff. So yes, everything Jeff mentioned is very, very important to make sure you have a good method to answering this question. So, you don't on test day just jump around and get confused and waste a lot of time. I think the most important thing here is the lead-in, just like you said. Make sure you read that, really understand what the question is asking. And this question is a small vignette, but sometimes you have huge vignettes where you have to kind of dig through there to find the key information. So speaking of key information, let's highlight some of the keywords in this question and what's important about this. So I always like to think about age and gender just to kind of have a visual understanding of what the patient is. If it's a younger patient, older patient, you got to have differentials come up with your mind based on that. So 37-year-old man is important. Diabetes and hypertension. Okay, that's just past medical. And he's having 100 milligrams of albumin in his urine in 24 hours. That's not a crazy amount, but there is some protein in his urine. He's prescribed a new medication that's going to improve his blood pressure and reduce albuminuria. Now, the first step is what? We have to think, what is this medication? And I think as a lot of you guys said, it's likely 2-step to 3-step question. You have to first think about what's happening in this, what do I want to give to this patient, and then how does that medication work? So which of the following effects is the patient's new medication most likely to cause? So once you kind of have that thought process, you build the understanding of that, you know what drug you're talking about, then I want you to look at the options. So let's have the options open right now. All right, so we have 5 options. This is the classic for USMLE Step 1, and you kind of want to keep the mentality and not just jump to the first answer you see, and just go through the options, make sure you have that one in your mind, and rule out the rest of them. So let's start with option A, decreased serum bradykinin. Option B, decreased efferent arterial tone. Option C, increased renal bicarbonate reabsorption. Option D, increased sensitivity of tubular glomerular feedback. And option E, increased sodium reabsorption in the collecting duct. Right, so lots of increases and decreases. It's important to understand what they're talking about and which part of the kidney they're referring to, or which part of the nephron they're referring to when they point at different parts. So I want you guys to take your time, think about what's going on here, and think of an answer. And then we're going to discuss the answer after the poll.
Okay, very good. So we have launched the poll. Go ahead and take a look and select the answer based on which of the effects you think that patient's new medication is most likely to cause. We didn't highlight it, but it is important to think about that modifier there. Most likely, right? You're going to have some of these that could happen, but which one is most
It's
likely?
important to always think about that as well. Yeah, sometimes they can say least likely as well, but the most likely is what you're likely going to see, and does not mean that more than one of these cannot be the right answer, but you want to pick the best answer possible.
Okay, looks like about 2/3 of you voted. I'll give you a few more seconds. We always remind you that you should never leave a question unanswered on test day or during question lab. You're not going to be penalized for it. So, okay, so almost 3/4 of you voted. I'm going to go ahead and close the poll. And let's go ahead and share the results. So a really strong consensus here behind answer choice B, decreases efferent arteriolar tone, and then answer choices A, D, and E came in roughly about the same percentage. Not many of you went with increased renal bicarbonate reabsorption. Okay, so with that, let's go ahead and hide the results and reveal the answer. And the answer is incorrect indeed. Answer choice B, decreases efferent arteriolar tone. Good job, everybody. This kind of a warm-up question. Kind of expect this one to be probably one of the easier ones of the evening, but you guys really knocked it out of the park. If you didn't get it right, that's okay. Abraham is here to walk you through it.
All right, so great job, guys. Yeah, again, this is one of the classic questions in nephrology, being able to understand the mechanism of the most common drugs we use in nephrology. Here, someone's got diabetes and hypertension. If someone ever asks you, hey, how am I going to treat this guy? Your reaction should be either starting an ACE inhibitor or an ARB. That's your go-to. All the drugs that end in pril or sartan are your friends in this situation. It's not only going to treat the hypertension, but it also has that renal protective or nephroprotective effect that we learned about. It's going to reduce the amount of stress on the kidney to reduce the albuminuria. Now, how does that work? That's where step 1. That's the basic science. You got to understand why it's happening. All right. This is less important as you kind of go more clinical, but for step 1, this is where they put the money. They want you to understand, okay, hypertension, diabetes, albuminuria, boom, ACE inhibitor, ARB. That's your go-to. Now, how does it work? Let's break it down, right? So ACE inhibitors and ARBs, they're very similar, but they're different actions. But at the end of the day, you're reducing the amount of angiotensin II that's being made. Either you're inhibiting ACE to prevent angiotensin I to convert to angiotensin II, or you're directly just blocking the receptor with an ARB. Either way, you reduce the effect of angiotensin II. Now, what does angiotensin II do? Well, number one, angiotensin likes to vasoconstrict. Okay? Now, if I'm vasoconstricting, I'm causing hypertension. So I want the opposite of that. So I'm blocking angiotensin II to vasodilate. Now, vasodilating in general is not going to protect the kidney, right? Why wouldn't calcium channel blockers like amlodipine protect the kidney then? No, it's specifically going to vasodilate more the efferent. So what is the efferent? EFF versus AFF. So not the afferent, the efferent arterial tone. It's going to vasodilate the efferent, so the exit valve for when the blood comes to the glomerulus is bigger. So the filtration will reduce. What is the problem in diabetes? If you go back and you go into the pathology of diabetes leading to kidney disease, it is hyperfiltration. All that sugar is damaging the blood vessels, causing what's called non-enzymatic glycosylation. Big fancy word, okay? But that's causing damage to the filtration to cause leakage of protein into the urine. That's why one of the most common complaints of someone newly diagnosed with diabetes is I'm peeing a lot and I'm thirsty all the time, because they're losing all this protein in the urine and losing sugar in the urine, which is taking water with it. So what can I do? If I give an ACE inhibitor or an ARB, I'm going to make the exit valve in the glomerulus bigger. The efferent arteriole is going to vasodilate, which means decrease tone. And that's going to reduce the filtration of the blood through the glomerulus. So you will treat the hyperfiltration, therefore reducing the hyperalbuminuria. Lots of little details there. That's very high yield stuff. This is the basis of nephrology, and lots of things are built on this. Other options, we'll quickly skim through them. Decreases bradykinin. Well, actually, ACEs and ARBs increase bradykinin. That's why the most common cause of discontinuation of ACE inhibitors is dry cough. The bradykinin causes a dry cough. That's high yield. If someone is on lisinopril and they're having a dry cough, switch to something else. Option C, increased renal bicarbonate absorption. That's not necessarily how that's going to work, right? So that's a whole different mechanism going into the acid-base stuff, not what's going on here. Option D, increased sensitivity of the tubular glomerular feedback. No, that's not what's going on here. It's not about the feedback. It's not working with the, the ability for the kidney to detect something and have that feedback system built in. And increased sodium reabsorption in the collecting duct. Not really. That's not what's going on here. The collecting duct is a whole different. We're talking about diuretics at that point, and diuretics would decrease absorption in the collecting duct. So totally not what's going on there. We're going with B as the best answer, and that makes total sense.
Okay, thank you, Abraham. So I hope you guys are taking notes out there. There's a lot that that we walked through and that Abraham explained. Which if you understand a lot of that, then you're going to be able to answer a ton of questions along these lines, and I think you're going to see some of that some thematic unity amongst the questions tonight. But what the idea here is to help really kind of reinforce some of the core knowledge that you'll need to be able to draw from and quickly draw from on test day. So anyway, great start. Let us head to question number 2. Again, we've got the answer choices covered up, and a little bit more meat in the this vignette. So let's go ahead, and we're going to start again with the lead-in. Which of the following glomerular lesions would most likely be found on a renal biopsy specimen in this patient? Okay, so we're thinking about lesions. We know that we're going to be checking out a renal biopsy here. So with that in mind, now that we kind of know what kind of data we're looking for, let's go ahead and read the vignette. A 59-year-old man comes to the clinic reporting lethargy, weakness, and bone pain over the past 2 years. History reveals a pathologic hip fracture 1 year ago. X-rays show several small hypodense lesions in the hip and spine. Serum protein concentration is 9, serum creatinine is 1.6, and urine dipstick shows 3+ protein and no blood. Serum protein electrophoresis reveals elevated gamma globulins with a monoclonal pattern. So again, the question, which of the following glomerular lesions would most likely be found on a renal biopsy specimen in this patient? Think about how many steps it will take to solve this one and put that in the question box as I turn it over to Abraham.
All right, so this is kind of the meat of the renal chapter, and this is what a lot of students struggle with from my side of view, the path side of it, being able to understand, hey, what am I going to see on biopsy? And that's where step one is king in terms of understanding the microscopic changes and things that are happening in the kidney secondary to an issue, right? The physiological stuff is very important. That helps conceptualize, and that's going to take you all the way to step three, but the micro effect and the pathology of it is what's going to be the focus, and that's what I'm focusing on today for our renal chapter. So some key important words here. Let's highlight some of these and let's talk about what the patient has and what I can expect. So again, last sentence is always the most important thing. The lead in, I'm thinking about which of the following glomerular lesions is found on renal biopsy. Okay, so I want some different biopsy options, and you can think about what's happening in the glomerulus. We got a 59-year-old man, so a little bit older outside compared to the last patient. Lethargy, weakness, fine, that's vague symptoms, but bone pain is important there. 2 years, so it's going to be chronic is going on. A pathological hip fracture, and then when they do images, there was hypodense lesions. So what does hypodense mean? It's not as dense, right? So what could that mean? I'm going to think about that. He has an elevated protein count. Okay, why would he have an elevated protein count? He has a creatinine elevation, 1.6, so higher than the baseline. And a dipstick is 3+ protein without blood, right? So lots of protein without blood should make you think one category of kidney injuries, okay? And just to make it easier for you, they gave you the final very clear sentence that's most likely the most important sentence in this is the protein electrophoresis reveals elevated gamma globulins with a monoclonal pattern. That's your diagnosis. So then you got to think about what does that mean? What is the diagnosis? And how is that affecting my kidney? Right? The kidney nephrology is a big multi-system chapter. This could be something other organ system is dysfunctioning, and this is leading to the kidneys getting affected. So I want you to think in that sense, think about what's going on and what can this condition due to the kidney, and that's what this question is really asking. So take your time, think about what's going on, and let's look at the options and try to come up with an answer. All right, so we got all kinds of pathology descriptions, and this is where the tricks are. You don't get overwhelmed. Some of these terms that you may hear, you probably are not super familiar with. It's okay if you haven't reviewed them in a while, but it's important to understand. So let's go through them. Option A, coagulative necrosis of the renal papilla. Option B, epithelial crescents. Option C, fibrosis of limited portions of some glomeruli without immune deposits. Interesting. Option D, mesangial and subendothelial deposits that stain positive for Congo red. And option E, podocyte foot process effacement on electron microscopy with normal light microscopy. Now, all this might sound like gibberish to you. If you haven't studied the renal chapter, that's totally fine. I still want you to give a guess, and we can still talk about this, and you can try to take something away from this question still. So take your time, think about what's going on, and let's go through these options together. Yeah.
Okay, the poll has been launched, so go ahead and make your selection. Due to the length of the distractors, the final one did get cut off, so it's supposed to say effacement on electron microscopy with normal light microscopy. And number D is that stains positive with Congo red, and option C is without immune deposits. So GoToWebinar is not they're just not ready for step one. They're not ready for the length of the distractors that you're going to see on test day. So looks like about half of you have made your selection. We'll go ahead and give you a little bit more time. Obviously a lot to parse, a lot to synthesize here.
And even if you don't know, just try your best and just pick an option that you feel could be correct, and we'll talk about it.
It looks like we've got one where again a lot of folks are homing in on one of these options. So we'll see if that ends up panning out. Okay, 3/4 of you have voted, so I'm going to close the poll and let's share the results. So again, over half of you, 56% of you went with mesangial and subendothelial deposits that stain positive with Congo red. About a fifth of you went with podocyte foot process effacement on electron microscopy with normal light microscopy. And then, a few more went with B and C, and maybe only a couple of you went with option A. So again, looks like we've got a pretty strong vote there for option D. Let's see what the answer is, and the answer is answer choice D. Mesangial and subendothelial deposits that stain positive with Congo red. Congratulations again. We are 2 for 2 so far, so that is excellent. But as Abraham said, this is some complicated stuff. Especially, I know that we've got some M1s here tonight, and there's some, perhaps some folks that maybe it's been a while. So don't fear. Abraham is here to help you walk through it.
All right, so great job, guys. Another tricky one here, but I'm glad you guys were able to get it. If you didn't get it, don't worry. This is a classic question, and the most important thing is coming up with a diagnosis, right? So they give you lots of hints here, and you may not necessarily get all of these hints, but it's good to catch what's going on, right? So this guy has elevated gamma globulins with a monoclonal pattern. That itself should make you right away think, okay, where are my gamma globulins coming from? From my plasma cells. So if my plasma cells are turning into cancer, this is called multiple myeloma. So multiple myeloma leads to a bunch of gamma globulins, right? Immunoglobulins are being secreted, and why is it a monoclonal pattern? It's all coming from one bad guy. One bad guy is replicating into a bunch of plasma cells, and that's secreting a bunch of these proteins that are depositing all over your body and causing problems. Remember, when you're not sure it's multiple myeloma, always think crab. That was a mnemonic that I remembered for step 1, and that stuck with me all the way till I'm a HEMONC fellow. So crab mnemonic is very important, and it's important, right? So C for hypercalcemia, R for renal injury, A for anemia, and B for bone lytic lesions. Okay, so in this case, they kind of focus on the bone lytic lesions. They gave you the renal injury and the proteinuria associated with that. But just to top it off, they told you the severely elevated gamma globulins. So what's going to happen if I have multiple myeloma? Well, multiple myeloma can lead to deposits and injury to lots of tissues, but the kidney is always the first one that is hit. Now, you can have multiple things that can happen to the kidney. First of all, you can have just myeloma leading to cast nephropathy, and that can cause light chains depositing in the kidney. But the other possibility, which is what's more likely tested, is that it leads to misfolded proteins. And these misfolded proteins are called amyloid. And amyloid is essentially just a bunch of proteins that are just garbage that just accumulate in our body that our body cannot break down properly. Okay, so these amyloids can then deposit in the kidney, all over the kidney, the mesangial, the subendothelial, and that leads to this damage to the kidney, and that's what's causing the problem. It leads to a nephrotic range proteinuria, right? So there's no blood. It's not nephritic, right? The main difference is nephritic, you got to think blood, hypertension, maybe post-infectious, maybe something else going on. Nephrotic, you got to think, okay, this is just lots of protein, so 3+ is definitely lots of protein, and not blood, right? That's what's going on here. Now, the Congo red stain thing, that's a buzzword. That's something that like you'll learn, that'll stick with you all the way throughout. Think about amyloid. And the other side of it is apple green birefringence. So you hear Congo red stain, apple green birefringence, think amyloid. Amyloid can come from many, many types. You can be primarily amyloidosis. Multiple myeloma can lead to amyloidosis. Tuberculosis can lead to amyloidosis. Rheumatoid arthritis. So anything where your body's making a bunch of immunoglobulins, those can get misfolded and drop into the kidney. Let's look at some of these other options here. So these are all very good options and important, and they're all in diseases in itself. So option A, we have coagulative necrosis. Okay, what does that mean? So coagulative necrosis is renal papillary necrosis. This can be seen in sickle cell patients and patients that take certain drugs where you get like necrosis of the actual papilla of the kidney, and less likely with the glomerulus. Epithelial crescents. So now this is when you see these like crescent shapes, fibrosis going on, and that can be seen in RPGN. rapidly progressive glomerulonephritis, which can be caused by multiple different things, but it's going to be more of a nephritic picture. It's going to see hematuria, it's going to have renal failure, and it happens very fast. Okay, this guy's been having it for 2 years, so you wouldn't think epithelial crescent. If it's happening over weeks or days, think epithelial crescent because it's rapidly progressive. Fibrosis of limited portion of glomerulus without immune deposits. Interesting. So why would you have fibrosis without immune deposits? Well, things like FSGS can cause that. It causes focal segmental glomerular sclerosis. Break down the word. Focal, one area. Segmental, one segment. Focal segmental glomerular sclerosis. So sclerosis is the fibrosis part. Limited portions of the glomeruli. That's the key word there. It's the causing that scarring, think of it like a pizza. You're just taking a slice of the pizza, and that slice of the pizza gets fibrosed. So the entire glomerulus can be think of a full pie, and you just take a whole slice out of there. All right, and option E, podocyte effacement on electron microscopy with normal light microscopy. Now this is the classic story. This is going to be kids most commonly. This is minimal change disease. It also presents with nephrotic range proteinuria, but a 59-year-old with multiple myeloma, that's not what I'm thinking. This is somebody who is a young kid and just with edema and proteinuria unexplained. That's why I'm thinking minimal change disease. The podocytes are affected, and we only see that on electron microscopy. And why is the name minimal change? Because on light microscopy, there's no change. Only on electron microscopy we see. So lots of little details there. Each of these could be a separate question in itself, and learning this and locking these concepts in is very high yield and will get you far for nephrology.
Okay, very good. So again, a lot of choice nuggets there. Hope you're capturing all of this. As a reminder, we do post all of the question lab recordings on our YouTube page. We'll share that link a little bit later on, but a lot of great teaching there from Abraham. So thank you so much, Abraham. Okay, so we are it's halftime. It's stretch break. I want you to get up out of your seat, stand up, stretch your hands above your heads. Tonight's question lab is brought to you by USMLE-Rx, the ultimate study tool for medical students, with thousands of high-yield questions, over 1,300 express videos, which is about 90 hours of material, over 13,000 flash facts, and the expanding innovative library of Rx bricks. We are here to help you excel in your studies and reach your ultimate goal of becoming a successful physician. Our platform is designed to adapt to your unique learning preferences, making the process of studying more efficient and effective. With our resources, you can confidently step into the exam room or the Prometric Center and achieve your best possible results. So don't just pass the exams, excel on them with USMLE-Rx. Your pathway to the residency of your dreams begins now. Okay, so now that everyone has stretched, we're going to start the second half of tonight's event. Again, we are going to have a raffle here at the end of the night. You do need to be here in order to win. So here's question number 3. And again, question's going to get a little bit more complex, right? So be prepared. Again, we've got the answer choices covered up, and we're going to start with the lead-in. Which of the following renal pathologies is most likely seen on this patient's renal biopsy? Okay, so now again, we know a little bit about what we're looking for, talking about another renal biopsy, right? So with that, let's go ahead and read the vignette. A 27-year-old woman comes to the physician because of 3 months of increasing shortness of breath with chest pain when she breathes in. She reports hand stiffness with pain and has noticed a rash on her cheeks when she is outside in the sun. Physical examination reveals swollen, tender metacarpophalangeal joints in both hands, decreased breath sounds at both lung bases, and a pericardial rub. Laboratory studies show white blood cell count 8,900, hematocrit 28.1%, hemoglobin 9.3, platelet count 87,000, blood urea nitrogen 36, creatinine 2.2. Urinalysis shows 3+ heme and 2+ protein, 8 to 10 dysmorphic red blood cells, by HPF are seen. X-ray of the chest shows large bilateral pleural effusions. Okay, with all of that, let's remind ourselves of the question. Which of the following renal pathologies is most likely seen on this patient's renal biopsy? Head on down to the question box. Let us know how many steps it's going to take for you to solve this one as I pass the mic to Abraham.
All right, thank you, Jeff. So another step up here a little bit. Lots of like little things, clues in this question. Again, another pathology question. Excuse me. And it's important to understand renal biopsies are like the meat of step one. So let's highlight some of the keywords here and let's go through what's important here. So again, age, gender, 27-year-old woman. I like to think about that. Some high yield stuff. So you got to think about what can a healthy 27-year-old woman have? Well, she's had 3 months of shortness of breath, chest pain when she breathes in. Now, if you guys have done some of the other chapters, that should already be ringing some bells. A young woman with chest pain when she breathes in. Some hand stiffness, okay. And a rash on her cheeks when she goes outside in the sun. Okay, you could kind of imagine what's going on here. Tender metacarpopharyngeal joints on both hands. Okay, we talked about that. And decreased breath sounds at both lung bases. Why would you have decreased breath sounds at the same time? And a pericardial rub. Okay, so these should all connect together. Think about unifying diagnosis. Think about something that would explain all these things together. If you look at the lab values, hemoglobin is low, 9.3. Platelet count is low at 87,000. BUN and creatinine, well, BUN looks like, it's a little bit high, but creatinine is significantly high, 2.2. Okay, that's important to keep track of. And the urinalysis, there's 3+ heme, 2+ protein. So this is a little bit different picture than the last one, right? There's blood in this urine. Less protein, more blood. What are we thinking? Okay. So it's a dysmorphic RBCs, sure. X-ray shows bilateral pleural effusion. That explains why there's decreased breath sounds. Okay. So what's going on? What am I going to see in this renal biopsy? And what is the association? So think of a unifying diagnosis, and same as the last question. Think of how it would hurt the kidney, and think about what would happen when I look at this kidney and what is the buzzword, quote unquote, that I have to catch for this. All right, let's look at the options. Let's go through them and let's talk about them in detail. So we got option A, linear deposits of IgG on the basement membrane. What is that? Option B, mesangial IgA deposits. Option C, necrosing tubular cells. Okay, that's a high yield one. Option D, pink hyaline nodules in regions of glomerular capillary loops. And option E, subendothelial glomerular immune complexes. Again, if you're not sure, think about what these options all mean and what condition is associated with each of these options. And that will help kind of lead you to the answer. All right, so take your time, go through it, and let's pick an answer.
Okay, we're going to launch the poll again. We've got some long answer choices. So again, answer choice D, it ends with glomerular capillary loops. So it just says, you only see the L here, but it should be loops. So go ahead and take a shot. Getting a little master class here in renal path tonight. So no better way to spend your Tuesday evening or maybe your Wednesday morning, depending on where you're at. Hope everybody is going strong out there. Again, we're going to have a raffle at the end of the night. Kat is going to draw the name of a lucky attendee. So we'll see. So make sure that you stick around for that. We also have a special offer for those of you who are participating. Okay, let's see. Almost well over 2/3 of you have voted. Give me a few more seconds before I shut it down. Make sure you get your answer in. Maybe you're trying to decide between two options. Go ahead and flip a coin. Okay, let's close the poll and share the results. So it's kind of interesting, in question lab, uh, we don't often see the audience, uh, you know, kind of homing in on one answer for for over half the crowd. So it's interesting that that's happened three times tonight, and perhaps part of the reason is we've got a lot of students in dedicated, maybe a lot of folks, and that are really focusing on in step one. Maybe that's part of it. I don't know, but 55% of you went with subendothelial glomerular immune complexes. About a fifth of you went with the pink hyaline nodules, and another almost fifth of you went with the linear deposits of IgG. So let's go ahead and hide the results and see if the majority rules again. And the answer is answer choice E, subendothelial glomerular immune complexes. Crowd, you've done it again. Great job. Um, there's a lot that you have to think through in these questions. So it's good to see so many of you, um, really kind of reasoning through it. If you didn't get it right, that's okay. Abraham's going to walk through this with you, and everyone should be tuning in here to, especially talking about the looking at those other options. So Abraham, I'm going to turn it back over to you.
Yeah, exactly like Jeff said. So great job, guys. You guys are actually knocking it out of the park. That is the correct answer. But more than just getting the correct answer, these kind of questions are all about, do I know what all the other options are? Because this question could be changed in a little bit, and the answer could be A, B, or C, right? So it's about looking at each of the options, understanding what they're talking about, and connecting the dots. So let's make those connections right now. So what diagnosis do you think this patient has? What would you diagnose the patient with? So lots of symptoms here. And yeah, so this is lupus. So this is SLE, right? So the rash on the cheeks, the joints affecting, the pericardial rubs. Why would somebody with SLE have a pericardial rub and effusions in the lung, right? So there's something called serositis that can happen, right? So you can cause inflammation of all things, right? So rash is like a dermatitis story. Joints is arthritis. If the pleura gets inflamed, it's pleuritis. And pericarditis, right? So all the itises can be seen in lupus. Lupus is just an autoimmune disease where your body is attacking itself with your immune system. Okay, so what does that mean, especially to the kidney? Well, lupus nephritis is very important. Okay, when I have association with lupus, I can cause kidney injury in multiple ways, and there's different types of kidney injury that can be associated with lupus. But the most important one that you got to be aware of is the one that causes the glomerular subendothelial deposits. Now, particularly in this patient, this guy has, or this lady has, nephritic syndrome. It's blood proteins, and I'm going to see these subendothelial glomerular immune complexes. Now, there is a very good distractor here. Option D, I think, is a great distractor because it says glomerular capillary loops, but it's pink hyaline nodules in the region, right? So that's different. So if I'm hearing loops, generally think lupus nephropathy, right? So they call it wire looping. That's the buzzword that you got to associate with lupus. So lupus causing, they mentioned the word wire looping, anything like that, where that's associated with the kidney injury. I got to think, okay, this is lupus nephropathy, which is what's happening here. And the subendothelial glomerular immune complexes is another way of expressing that. Now, this is different than my subepithelial. This is subendothelial, and that's kind of the key important takeaway from this point. Let's go through these other options, and these are actually all very high yield topics in itself. Option A, you guys should have somewhat of an idea what this is. Whenever I hear linear deposits on the base membrane, there's only one thing that's linear. That is Goodpasture syndrome. Goodpasture syndrome is an autoimmune disease where you have antibodies against the glomerular base membrane, and they line up nice and neat in a straight line all over your glomerulus and causes linear deposits. Whereas these immunofluorescence descriptions, that's what they're describing here, right? Linear deposits on immunofluorescence. You have to kind of know the difference, right? So if it's linear, it's always Goodpasture. Most of my lupus, post-infectious glomerulonephritis, all these ones that are depositing into the kidney are not going to be linear. It's going to be granular, where it's like hazy appearance. while there's posse-immune, which is the final one, which doesn't have any deposits, and those are going to be my ANCA ones, or my vasculitis associated nephritis. Mesangial IgA deposits, well, it gives it away. IgA, right? This is the one where if I get illness and then a few days later I'm peeing blood, yes, that is post-infectious, quickly leading to nephritis. Whereas if it's a long time, like 10 days plus or a week plus, then I'm thinking more the post-infectious, and that's the post-strep GN, like we learned from before. Necrosing tubular cells, that's a quick one. That's ATN, acute tubular necrosis, seen in sepsis, hypotension, drugs related. Those are high yield as well, and that causes those casts that you should be aware of. And the final one here is pink hyaline nodules in the region of the capillary nodes. Whenever I think pink hyaline, think Kimmelstein-Wilson nodules. Those are diabetic nephropathy nodules. So lots of good options here. These are all high yield, and I would focus on getting a unifying diagnosis and then connecting it to the pathology.
Okay. Well, you've gotten your prescription there from Dr. Titus. So good, great breakdown there, and hopefully a lot that you can take with you going forward. Okay, we have reached the end of tonight's session. This is question number 4. You guys have done an outstanding job tonight. This has been very impressive, and we're going to see if we can close it out. See if we can go 4 for 4. And to do that, we're going to need to answer this one. So again, we've got all those answer choices covered up, and we're going to start with the lead-in. Which of the following is most likely to be found on microscopic evaluation of a renal biopsy specimen? Okay, so again, you see where our focus is tonight, and you know just how important having this under your belt going into to step 1 is going to be. So with that, let's go ahead and read the vignette. A 12-year-old boy comes to the physician's office because of 24 hours of leg swelling and dark urine. He had a sore throat and fever 2 days ago. Current blood pressure is 130/92. Physical examination shows edema in both ankles. Subsequent urinalysis shows hematuria, RBC casts, and proteinuria of 2.5 grams a day. Serum complement level is normal. Cultures for gram-positive bacteria were negative. So again, which of the following is most likely to be found on microscopic evaluation of a renal biopsy specimen? Let us know how many steps you think it's going to take to solve this one by going down to the question box as I turn it over to Abraham.
All right, so we have another situation of bloody urine. Right? This is a classic situation. We got to think about what's going on. We got to connect the dots, and we need to think of a unifying diagnosis, and then again, connect it to the pathology. I really felt that this is something that you guys should really put some focus on, and it'll really help you, especially for step 1. And that's going to be a lot of the nephrology pathology questions. All right, so let's highlight some of the key words here, and let's make our way through this question. So again, now we're dealing with a kid this time, 12-year-old boy. All right, you got to think about what would happen in a 12-year-old boy. Well, you got leg swelling and dark urine. Interesting. So why is he having leg swelling and dark urine? Sore throat and fever 2 days ago. That's important to know. Blood pressure is a little bit high. You know, we for a kid, that's pretty high. We kind of have an association there I'm going to talk about. And you have hematuria, RBC casts, proteinuria of 2.5 grams per day. And what does RBC cast mean? What does that proteinuria mean? What does that hematuria mean? And serum complement levels are normal, gram-positive bacteria negative, sure. But what am I going to see on a microscopic evaluation? What's the diagnosis and what am I going to see? So let's look at the options. If you guys are paying attention, you guys should be able to get to the answer to this one, okay? Let's go through each option here and let's talk about it. So option A, dense deposits within the basement membrane. Option B, mesangial immune deposits. Option C, podocyte effacement with otherwise normal glomeruli. Option D, subendothelial basement membrane deposits. And option E, subepithelial humps. All right, so what do you guys think is going on here? Think of an answer. Think about what's happening with this patient and why they're presenting like how they're presenting, and then connect it to the pathology.
Okay, so we have launched the poll. And all of the distractors fit this time, so you've got everything you need in order to answer the question. Go ahead, take a shot. Let's see if we can keep the streak alive. Got a couple of, again, we've got the raffle, we've got a special offer. Just put a link in the chat to our Rx study planner. So if you're looking for a study planner for step 1 or thinking you might need one for step 2, good way to help yourself get organized and plan your studies accordingly. Okay, let's see. About 2/3 of you voted. I'm going to keep the poll open for just a few more seconds, and then we're going to have to close it down. Okay, so go ahead, take a shot. This one is a tougher question. I can kind of see the some of the hesitation out there. That's okay. Let's go ahead and I'm going to go ahead and close the poll here, and I'm going to share the results. Okay, so almost 40% of you went with mesangial immune deposits. Battle for second place between subepithelial humps and podocyte effacement with otherwise normal glomeruli. And then some of you went with the subendothelial basement membrane deposits and the dense deposits within the basement membrane. So not the same kind of consensus we've seen with the previous question. So definitely a little bit more challenge. So let's go ahead and hide the results and reveal the answer. And the answer is answer choice B, mesangial immune deposits. And folks, you know what that means? It means we've gone 4 for 4 tonight. We've swept it, and that deserves a real celebration. If you didn't get this one right, that's okay. This one was a little bit tougher, so Abraham is going to walk you through it.
All right, great job, guys. You guys beat me on this one as well. So this is another tricky one here with lots of good distractors. I like all the option choices here, and really it makes you kind of lock in on the differences between some of the similar things, right? So whenever I think a little kid with kidney issues, a few things should pop into my mind, right? So minimal change disease should automatically be there, your post-infectious stuff should be there, and your IgA nephropathy should be there. So those are kind of your most common stuff you're going to be thinking for kids. Membranous can also sometimes present like that with cancer. But first thing I should do is categorize this guy as is it a nephrotic syndrome or a nephritic syndrome? Again, breaks down. If I see RBC Cas, if I see blood in the urine, if I see less than 3 grams of protein, this is a nephritic syndrome. Nephritic syndrome is associated with bad kidney injury and hypertension. That's the big association. So that's why his blood pressure's up. Nephrotic, I'm thinking more than 3. And I'm thinking fatty casts, not RBC casts. So casts are important as well. Casts can be a buzzword sometimes, but don't fall into the trap. Only they don't always give it to you. RBC casts, nephritic, fatty casts, nephrotic. Proteinuria, more proteinuria nephrotic, less proteinuria nephritic. Hematuria, nephritic, no hematuria nephrotic. That's your thought process. Okay, so this is a nephritic syndrome in a kid. So right away, if I know it's nephritic, I know minimal change disease is a nephrotic syndrome. So that's going out the window, right? That's a really good distractor. If I see a little kid with leg swelling, minimal change is my first thought, but he shouldn't be peeing blood. So right away, this podocyte effacement with otherwise normal glomeruli, that's how they classically describe minimal change disease. Option C goes out the window. All right, so we're left with the rest of the options. All right, now let's break down what the rest of the options are and think about what's happening to this guy. Well, he had a sore throat and fever 2 days, and then he got hematuria. Well, you know, we were trained to think when I hear sore throat and then blood in the urine, oh, it has to be strep and post-strep glomerulonephritis. Not always. That's the trap. They love to do this because they know we are trained to think that way. Post-strep glomerulonephritis takes at least about 10 days, usually 2 weeks to happen. It doesn't happen right away. The acuity and the speed at which his symptoms developed, that he got a sore throat and then literally 2 days later he's peeing blood, that's too fast. That's not post-strep. That is IgA nephropathy. And IgA loves to deposit in the mesangium. Think about IgA and mesangium, connect those together. IgA deposits in the mesangium, it causes IgA nephropathy. And that's what's going on in this guy. Now, which one of this is the post-strep? And you guys put that as one good guess too. Subepithelial humps is the post-streptococcal or post-infectious. They kind of change the name interchangeably sometimes because staph can also cause it sometimes. Glomerular nephritis. So acute post-strep glomerular nephritis is subepithelial humps. We talked about some of these other ones, subendothelial deposits. We just talked about it. That's lupus, right? This kid doesn't sound like he has lupus, right? You have a 12-year-old coming in sore throat and then peeing blood, unlikely to be lupus. It's probably the infection causing something that's causing damage to the kidney. And that's what that association is. Podocytophasia, like we talked about, that's minimal change disease. The mesangial immune deposits is the correct answer. That is the IgA depositing. And then what's option A? Dense deposits within the base membrane. That's a condition called membranous proliferative disease. And that's got to do with hepatitis C, typically old people that are have contracted hepatitis C. That's going to be your step 1 association. Unlikely. Okay, so in summary, think about, is this a nephrotic or nephritic syndrome first? Don't get caught up with the age right away. The age is important, but always separate those two in your mind. Okay, and you have your list of nephrotics, your list of nephritics, and then look within those. Then timing from sore throat / infection, doesn't have to be sore throat, can be a rash, can be anything else, to bloody urine. That's important. Okay, post-strep ones take at least 10 days to 2 weeks to happen. Anything that's early, like 2 days, 4 days, 5 days, think IgA nephropathy. That's the high yield stuff. Great job, guys.